Good afternoon, everyone, and welcome to Scleroderma Interstitial Lung Disease presented today by Dr. Shane Shapera. Dr. Shapera obtained his Doctor of Medicine in 2003 from the University of Toronto and went on to continue in Toronto during his internal medicine and respirology residency training. He completed an additional year of clinical fellowship in interstitial lung disease in 2010. He's an associate professor and clinician educator in the Faculty of Medicine at the University of Toronto. He's currently the director of the Interstitial Lung Disease Program at a Toronto General Hospital, which is part of the University Health Network. He also works with the Toronto Lung Transplant Program, providing pre-lung transplant assessments for patients with interstitial lung disease. And I also want to let everyone know that Dr. Shapera is also a member of the Canadian Pulmonary Fibrosis Medical Advisory Committee. Thank you, Dr. Shapera.
Thank you so much. It's a pleasure to chat with you today. The last time I gave a talk was back in the beginning of April, and we were talking about COVID-19, and it's made me reflect on how much things have changed since that time. And I'm thrilled today to talk to you all about scleroderma-related ILD. So here are my disclosures. So I've been working with lots of different companies that have been developing treatments for pulmonary fibrosis and interstitial lung disease. I've been involved both with research and in an advisory capacity. My other disclosure that I'm going to make today is to let you know that there are very few approved therapies to treat connective tissue disease related ILD. So I want to be really open with the audience before we get started to let you know that pretty much everything except for one treatment that I'm going to talk about today is what we would call off-label, in the sense that based on Health Canada and the FDA in the United States, these drugs do not have an indication for scleroderma, but we extrapolate from the data and use those drugs even though it's considered off-label. So my goal for today is that our audience at the end of our talk will be able to describe what do we mean when we talk about scleroderma-related interstitial lung disease, that they'll understand the risk factors for scleroderma development and its progression, and then they'll be able to discuss both general treatments and more specifically, treatments that are targeted against the anti-inflammatory components and the anti-fibrotic components of scleroderma ILD. But before we begin, I have to define some medical terms, and everyone always hates when we have to have some medical jargon, but in order to make sure we're all on the same page, I'm just going to define a couple of the terms that we're going to talk about. What do we mean by interstitial lung disease? And I love this picture. This is a picture of the lungs here on the left, and you can see that essentially the lungs have three different components. What you'll see is the blue here is the blood vessels. You'll also see the tubes or the airways going through here. And then you have all this other stuff. And I want to kind of show you that this part is what I'm blowing up right here. This is the lung tissue itself. And in that tissue, you have this area called the interstitium. So what is the interstitium? So the interstitium in this picture is exactly where the red arrow is pointing. It's this lattice work, or almost like a beehive, of little interconnecting holes and scaffolding. And essentially the way I think about the interstitium is it's the scaffolding that holds the rest of the lungs together. If the lungs were a building, you would think of the interstitium as sort of the girders and the floorboards and all the things that make up the building itself, whereas the airways would be the hallways in the building and the blood vessels would be the plumbing. So that's when I think of the interstitial diseases, we're talking about things in the scaffolding of the lungs, or the part of the lung that holds the rest of the structures together. What is an interstitial lung disease? So we talked about what the interstitium is, but what is a disease of the interstitium? Well, these are chronic progressive scarring conditions of that scaffolding of the lung. And the cause may be known, so for example, scleroderma or asbestosis or farmer's lung, or the cause may be unknown, and the typical unknown progressive fibrotic lung disease is idiopathic pulmonary fibrosis. Why is it bad? Well, everybody on this call probably knows why it's bad even better than I do. Stiff lungs cause you to have to do more work to breathe. You have to do more work to stretch out those lungs, and that makes you feel breathless. Scarred lungs are not very good at exchanging the oxygen. So when that scaffolding gets thicker, it's hard for you to exchange oxygen from the lungs into the airway and vice versa. And that leads to low oxygen levels into the blood. And unfortunately, most of the interstitial diseases that we see are progressive, and so they get worse over time. The second piece of terminology that I need to define is to give you a sense of how do we assess these interstitial lung diseases. And so as you can see from this diagram, what you're looking at right now, that red line, is this pair of cartoonish lungs that's breathing in and out. And the air that's in the lung is going up and down with that red curve. Now imagine that you start to take progressively deeper and deeper breaths. And as you start to breathe deeper and deeper, eventually you'll breathe from basically all the way full to all the way empty. Now the lungs never entirely get empty, but you get down as low as you can go. And that difference, that amount of lung that you blow out, when you blow from totally full to as empty as you can go, that measure is called the vital capacity. And that's the second term that I wanted to define before we move forward. Now let's talk just for another moment about this vital capacity. So as the lungs stiffen and get thicker from this interstitial disease, they start to shrink. And when the lungs shrink, that vital capacity, how much air you can get from totally full to as empty as you can go, that gets smaller. And so we see that as everything gets smaller, the vital capacity will get smaller with it. And we measure that vital capacity by asking our patients to force the air out of their lungs. And many of you will have done this, where you put the spirometer in your mouth and we say, take a big breath in and blow it out as far as you can go. And so we monitor the volume of that forced vital capacity. And that gives us a sense of how much scarring is there and how much have your lungs shrunk. And this measure that we talk about is the FVC, or the forced vital capacity. And you're going to hear me talk a lot about the FVC as we go forward in today's talk. When we see a dropping FVC, that again would make you imagine that the lungs are then getting more shrunken, stiffer, and that means that the ILD is getting worse. So that's my medical jargon 101. Now let's start to talk about who gets scleroderma lung disease. So scleroderma lung disease seems to occur in about half of patients who have scleroderma. But the clinical course is really variable. So I've followed many patients who have mild and stable ILD from their scleroderma who might have had that for years, sometimes even decades. I follow a couple of patients who were diagnosed with scleroderma lung disease in the 1970s. On the other hand, there are other patients who have very severe and or rapidly progressive disease. The job that's the doctor's job is to try and predict who will have milder disease and who's going to have more progressive disease over time. Now, we do have a few ways that we're able to predict, and there's a few risk factors for progressive ILD. The 5 main risk factors that doctors think about when they're worried about whether or not a patient is at high risk of progression are right here. So the first one is, how recent was your diagnosis of scleroderma? We sort of think of scleroderma in some patients as kind of like a fire that burns really hot at the beginning, and then eventually it can kind of burn out. And so particularly we know that in the first 4 to 5 years, if that's when you're diagnosed with your ILD, because your disease is kind of fresh and hasn't burned out yet, you're at a higher risk of having progression of your ILD. There are specific antibodies that are associated with progression of the ILD. So there's an antibody called a topoisomerase antibody. The other name for this is an anti-SCL70 antibody. That's just the name we give it. And that topoisomerase antibody is much more likely to cause progression of the lung disease than other scleroderma antibodies. So there is another scleroderma antibody called an anti-centromere antibody. And the centromere antibody tends to give people more other lung conditions like pulmonary hypertension and less of the pulmonary fibrosis. The third major risk factor is how much of your lung is involved at the time when you come to an ILD clinic like mine. So if you come to my clinic and you've got, just a tiny bit of disease, maybe only 5% or less of your lung that's involved, your chances of progression are much lower than if you come to me and you already have 20 or 25% of your lung involved with the disease. Similarly, if when you get to me, your lung function is already low when you first get to me. So now we've talked about what we mean by this FVC. So if your FVC is less than 70% of normal when you first get diagnosed with your scleroderma, that would suggest that you're at a higher risk of progression. And we think that probably is just because it means that your disease has already progressed, right? If your lung volumes are only 70% of normal, well, you weren't born with lungs that were 70% of normal in size. So that is already sort of proof that you're someone who's progressed in the past, and that predicts progression in the future. Along those same lines is the last risk factor that we should talk about, and that's a dropping lung function over time. So if your FVC drops by 10% over a 6 to 12 month period, so what we mean by that is, for example, if your vital capacity or FVC drops from 2 liters down to 1.7 liters, that's a 300 milliliter drop. That's more than 10% of your original 2 liters. And when we see that 10% drop in lung function, that predicts worsening lung function over the next year. So now that we've talked a little bit about what we mean by ILD, how we measure it, and we've talked a little bit about the risk factors for people getting worse, now I thought we could talk a little bit about a case where a patient is getting worse, and we can talk about what we do for patients when they're getting worse. So this is a patient who's a 58-year-old woman with scleroderma. To be honest, she's all of the details of her case, including her initials and her location where she lives, is made up or changed, but the actual case, the breathing tests and the CAT scans are from a patient that I follow. This patient lived at far distance from my clinic in Toronto. So this is for those of you who are not from close to Toronto or live in our province. This is a very long drive, a couple of days to drive, and an airplane flight to come to see me in the clinic. She was referred to me in 2008 for a lung assessment. So this is one of the earliest patients I saw when I was just finishing my fellowship. When I saw her in 2008, she was fit and active and did not have any lung symptoms. At that time, we said, okay, well, you might have a little bit of lung disease, but there's nothing too exciting here. Go back home and I'll just check in with you every once in a while. When I saw her 3 years later, now things were changing. At that point, she was describing feeling breathlessness for the past 6 months. She developed a dry hacking cough, and her cough was slowly getting worse over time. Her family doctor had tried antibiotics and puffers, and it really hadn't made much of a difference. This is what her scan looks like. So I want you to try and remember that picture that I showed you before. This is a picture of this patient's lungs. She's looking at us like she's looking in the mirror. In the middle of the screen, you can see her spine. And on both sides, these gray things that you're seeing are her lungs. And in particular, what I want to draw your attention to is this area within the red circles. And if you remember how I was showing you before, what you're seeing here is a thickening of the interstitium. And you can almost imagine that this picture that I'm showing you in the top right that was from, it's an electron microscopy of someone's lungs, you could almost imagine if each of these little lines going around here got a little thicker, you could imagine that this is what it might look like on a scan. So again, to just remind you, this part on the top, in your top left-hand corner of the screen, that dark gray lung, that's normal lung. It's this part in the red circles at the bottom, that extra white, kind of lacy lattice work of lines. That's the interstitial disease. Here's what her lung function test had looked like. Back when I saw her in 2008, her FVC, or her forced vital capacity, was 2.3 liters. When she came back to see me in December of 2010, her volumes had gone down to 2.0 liters. So you're now starting to see that that's more than a 10% drop. She's gone down by 300 milliliters, so it's a bit more than a 10% drop. But that was over 2 years. So to be honest, when I saw her at that December 2010 visit, we didn't get too excited. What I said is, okay, I'm a little worried. I'm certainly not going to wait a long time before I bring you back. But why don't I plan to bring you back in about 6 months, and we'll see where things are going. And we'll see if this is just sort of fluctuating or if this is actually showing progression. When I brought her back 6 months later, she had dropped by even more, and her vital capacity was now 1.7 liters. This is very worrisome. So I was concerned. And we talked about treatment. And so at that time, when we talked about treatments, we didn't just jump into fancy, expensive drugs. The first thing we talked about is the general principles, the back to basics of treatment. And this is what I sort of call motherhood statements, stuff that we know that we should do as doctors, stuff that our parents told us to do, but we want to re-emphasize it for our scleroderma patients when they're getting sick. So the first general principle that I always use when I'm seeing a patient with scleroderma is that I think that we need to screen for and treat other causes of coughing and breathlessness. We know that patients with scleroderma can get heart problems or pulmonary hypertension. We also know they have lots of problems with their swallowing tube or their esophagus, so they can get acid reflux, which can cause cough. Also, they can become very deconditioned, or that's the medical term for basically being out of shape. And it's very common for our patients who don't feel great to spend a lot more time than regular people sitting on the couch. So we need to try and fight against that by giving them pulmonary rehabilitation or getting them active and exercising, especially if that's available. Now, it's not unfortunately available everywhere around the world, but if it is available, that's something that we strongly consider. The next general principle is vaccinations. So we know that our patients who have underlying lung diseases, if they get illnesses, whatever that illness might be, if it affects the lungs, they're already starting at a disadvantage, and so they're more likely to get sicker than other people. So we strongly recommend that all of our scleroderma patients should have an influenza vaccine every year. For those of you watching this, those influenza vaccines are going to be coming out in about the next 4 to 6 weeks, and I would strongly recommend that you all get it. Pneumococcal vaccines, or this is pneumonia vaccines, those don't need to be given every year, but we recommend that our patients get them somewhere around every 5 to 10 years. No one knows the exact right amount of time between vaccinations, but you probably want to repeat it every 5 to 10 years. Eventually, if a COVID-19 vaccine does come out, then I would, of course, strongly recommend that everybody with scleroderma gets it, although to be honest, I'd recommend that everybody gets it. Then the question is, well, that's easy to do the motherhood things, but when do we start to really think about treating our patients with our drugs? And this is not an easy question to answer. And the reason it's not easy to answer is because when I see a patient with scleroderma lung disease, I don't know how active their disease is. I often see patients who have early disease that was sort of found incidentally. Someone had a little bit of a cold, someone did a chest x-ray, it showed something, but the cold went away and now they have no symptoms. But because there was something on the x-ray, they went on to do CAT scans and get referred to me. If they have no symptoms and their disease is really mild, we might call that subclinical disease, where it's really early and mild. Similarly, and that may not need treatment. Similarly, on the other end of the spectrum, if you have, as we were describing before, this burned out disease that you've had for 10, 15 years that hasn't changed much, that may not require treatment. Like that fire we talked about, it may have already burned itself out. We also have to balance the risks and benefits whenever we think about starting patients on drugs. It's important to remember that the treatments are largely based on relatively poor quality data, and I'm going to show you that data. It's not bad quality, it's just relatively poor quality. We don't have amazing studies. This is not the same as, for example, the data we have to show that you should take aspirin if you have a heart attack. You know, that's really good quality data, and nobody doubts that. Some of the scleroderma literature, it's just not as high quality, and so we have to be cautious about how we interpret it. Also, once we start treatment, it's usually maintained for years. So we're committing people to being on treatments maybe for life, at least for many years. So we should be really cautious before we jump in. In my mind, treatment is usually started in my clinic when patients have two things. They have to have abnormal lung function, and they have to be showing me that their lungs are getting worse over time. Is that the right thing to do? I don't know. In some diseases like IPF, we are starting to treat patients earlier and earlier in their disease because we know that everybody gets worse. I still don't know if we know if every patient with scleroderma should be on treatment. But if you meet these criteria, abnormal lung function and worsening lung function, I think there's no doubt that those people should be on treatment. But the question is, should we be starting treatments earlier? And that's something that our community is still hotly debating. So if you are going to use treatments, what are the treatments that are available? There are lots of small studies, tiny studies of different experimental type things, but I'm going to focus today's talk on 4 specific treatments that you might be hearing about from your doctors. We're going to talk about cyclophosphamide, mycophenolate, rituximab, and nintedanib. So first, let's talk about cyclophosphamide. We're going to talk about this first because this was the first one to really be studied in a meaningful way. And this was studied in a study called the Scleroderma Lung Study 1. At the time, I think they just called it the Scleroderma Lung Study. This was published in 2006. And in this study, what they did is they gave a drug called cyclophosphamide taken as a pill, and they compared that to people taking a placebo for 1 year. So they had 158 patients. They gave half of them cyclophosphamide and half of them placebo. Here's what they found. This is a graph, and I'm going to walk you through what we're seeing. On the horizontal axis, you see time. So as we move to the right, we're going further and further forward in time. And on the vertical axis, you're seeing lung function, or FVC. And what we see is that the treatment group, that's the top line with the empty circle for each dot, you can see that at the end of 1 year, there were slight improvements in their lung function. So what we mean by that is that this dot, which is the lung function of the cyclophosphamide patients, shows a slightly higher lung function, or FVC, than this black dot, which is the patients who are on placebo. But you can see the differences there are not very dramatic. Interestingly, even though we only treated these patients for a year, at 18 months, we actually saw that their lung function went up even further. So the drug seemed to have some effect even after it had been stopped. But at a year off treatment, or at the 2-year mark, both the placebo arm and the treatment arm were essentially at the same place. There were lots of side effects in this study. So cyclophosphamide can cause low blood counts, bladder problems, and it's even been associated with increasing your risk of certain kinds of cancers. So what's the take-home message of the Scleroderma Lung Study 1? The take-home message for me of this really pivotal study published in the New England Journal of Medicine, which is the top medical journal, this study showed that cyclophosphamide is the first drug that was shown that it can improve lung function in patients with scleroderma lung disease. Some benefits continue for 6 months even after the drug is stopped, and the lung improvements seem to peak around 6 months after finishing the treatment. But overall, the benefits were relatively small, and if you stop the treatment, the benefits seem to fade over time. A year after stopping the treatment, these patients had essentially lost all of the benefits, and they were exactly the same as the placebo arm. Also important to note that side effects were common and can be serious with cyclophosphamide. This is sort of how you feel when you think about the cyclophosphamide effects. You know, you're stuck with it at the time, but you really wish you had something better. I'm not going to get too political, though. I know we have people from all over the world, and so I'm not going to get my politics into it. But what this does bring up is, are there other less toxic treatments that might work as well? And that's what led to this study. This is the Scleroderma Lung Study 2, and this was presented in 2016. What this study did is it took 142 patients and it randomized them into two groups. Half of the patients got cyclophosphamide, which you're now familiar with. That was the drug we just talked about being given in the Scleroderma Lung Study 1. The other half got mycophenolate. And here's what that study showed. Now you're getting used to these graphs. So again, on the horizontal axis, you're seeing time, and in the vertical axis, you're seeing lung function. And what do you see here? So interestingly, the lung function improved by a similar amount in both the cyclophosphamide group and in the mycophenolate group. Not surprisingly, though, we saw more side effects with cyclophosphamide because cyclophosphamide is a pretty toxic drug. Now, it's important to know that officially this study was negative. This was a negative study. And the reason for that was the people who designed the trial, their goal was that they thought mycophenolate would actually be better than cyclophosphamide. They didn't show that. You can see these two curves are basically overlapping on top of each other. So by the official study design, this was a negative trial because they did not show that mycophenolate was superior to cyclophosphamide. But this does suggest that both drugs seem to work and by similar amounts. But it's important to say that the study was not designed to show that they were equivalent. It was designed to show that mycophenolate was superior, and it didn't show that it was superior. It ended up kind of showing that they were equivalent. And we have troubles with how with that because we design studies differently depending on what kind of differences we're meaning to show. We didn't design this to show that they were equivalent. So it's a little hard to draw conclusions. But there's other data that came out of this study that I think is probably even more meaningful than these small changes in lung function. Particularly what we're seeing is data about quality of life. And there are lots of different ways that we measure quality of life. But this method that I'm showing you in the graph here is using something called the TDI, the Transitional Dyspnea Index. And it doesn't matter what they're talking about. Essentially, this is a measure of quality of life. And as you get higher in your TDI, your quality of life is better. And so what you can see is they measured the quality of life in this Scleroderma Lung Study 2. And what they showed is that both for cyclophosphamide and mycophenolate, you're seeing a very clear trend that both of these lines are going up over time. So as you go on these treatments, quality of life actually seems to improve. And so even though we're not 100% convinced that mycophenolate is better than cyclophosphamide, or even we haven't really proven that mycophenolate works when compared to a placebo, I think it's pretty reassuring that both mycophenolate and cyclophosphamide seem to improve quality of life in patients with scleroderma. So what's my take-home message of the Scleroderma Lung Study 2? So my take-home message here is that cyclophosphamide and mycophenolate both likely improve FVC or lung function. But what's also really clear is that cyclophosphamide seems to have more side effects than mycophenolate. So, you kind of want to do a dance, but we all remember how this dance ended. And maybe we're dancing too early because there's still lots of unanswered questions when it comes to cyclophosphamide and mycophenolate. The real question is, can we really make any conclusions from this negative trial? And I will tell you that we use a lot of mycophenolate in our clinic, and we sometimes use cyclophosphamide as well. But we're all sort of still a little bit uncomfortable with this idea that we don't have amazing data to suggest that it is definitively effective. We also don't know if there are some patients that might benefit more than others. These studies kind of just give everybody the drug. But the question is, are there subgroups that would really derive more benefit from one drug or the other? We still don't know when the right time is to start these drugs, as I talked about before. And there's still a lot of debate about whether or not you might use these drugs in combination, or more likely if you'd use them sequentially. So is there a role for cyclophosphamide first, give that for a year, and then follow that up by mycophenolate? Or should we use cyclophosphamide as salvage therapy if patients who are on mycophenolate get worse? If one drug isn't working, would the other one be likely to work? We don't know those answers, but we do have our clinical experience. And so again, I've made up the names of this patient, but the numbers that I'm showing you are real. This was a real patient that I followed. And this patient, who had been getting worse, had a detailed discussion with me, and we decided together back in 2011 to start her on cyclophosphamide. And I gave it to her for 6 months, not 12 months, because she was worried about the side effects. But even back in 2011, years before the Scleroderma Lung Study 2 had been published, we had a sense that mycophenolate may be effective. So even back then, I decided at the end of her 6 months of cyclophosphamide, I gave her long-term mycophenolate over the next 2 years. And I want to draw your attention to the fact that by the end of her treatment, so she's now been on treatment for about 3.5 years, I got her lung function better than it had been even back when I saw her in 2008. Now, not everybody would have those benefits, but this is a case that shows me exactly what I'm trying to show you guys, that our treatments may not have the best evidence, but our experience shows that they can be effective. Would I do things differently now? Would I do things differently now? The answer is I probably would. Back in 2011, we didn't have the Scleroderma Lung Study 2, but in 2020, we do. And so these days, I tend to use mycophenolate before cyclophosphamide because I think it probably does work just as well, but has a lot less side effects. The next drug I want to talk about is a drug called Rituximab. So Rituximab is in a group of drugs called biologics. And biologics are often used to treat rheumatoid arthritis and other rheumatologic conditions. The way we give Rituximab is instead of giving it as a pill like the other drugs we've talked about, this is given as 2 injections 2 weeks apart, and we repeat that every 6 months for a total of 4 doses per year. What Rituximab does is it destroys the antibody-making cells in the body, or the B cells. And we think that's useful because these antibodies seem to play a role in the disease. If you remember earlier on in this talk when I talked about the risk factors for getting worse with your scleroderma lung disease, I mentioned that having a certain antibody profile, that anti-SCL70 or that topoisomerase antibody, if you've got that in your blood, you're more likely to get worsening ILD. And so we think that these antibodies are playing a role in causing the ILD. So the hope is if we go into your body with this medicine and we destroy all of the body's ability to make antibodies, maybe that will stop the progression of the disease. Now, the question that my patients always ask me is, well, don't we need our antibodies? And the answer is yes and no and maybe. There's no doubt that we use our antibodies to fight off infections. And so Rituximab, when you take it, is associated with an increased risk of infection. But the flip is that most patients have very few side effects. And we're going to talk about whether or not it's effective or not. And so we have to do this balance of risk of infection versus risk of the lung disease progressing. So this is just one paper that I'm going to show you that was published in 2017. This is a slightly different kind of study than the ones I've shown you before. This is called an open label study. So this is where, in this clinic, they offered all of their patients with scleroderma, scleroderma lung disease, they offered them to use Rituximab. And they gave them the option to either try Rituximab instead of whatever drug they were using at that time, or they could just stay on their current treatment. And so they found 51 patients who wanted to be part of this study, and they followed them for 4 years. And of those 51 patients, 33 of them chose to change their treatments and start on Rituximab instead. 18 of those patients said, you know what, I want to be part of your study, but I don't want to use your Rituximab drug. I'm just going to stay on my current treatment, which is what was called standard of care. And here's what they showed. The people who took Rituximab that was associated with an improvement in their FVC over the standard of care treatment at 7 years. And the differences were actually quite large. So if you look at this graph, you can see that if we started everybody here, the people who got standard treatment, that's the blue bars, those people, their lung function just went down over time. Whereas the rituximab patients, their lung function actually increased over time. There was actually a really big difference with the rituximab patients having their lung function go up by 11.5%, and the standard treatment arm, their lung function went down by 16.6%. Now, this is not the same as the other studies, the Scleroderma lung study 1 and 2 that I mentioned, because this was not randomized. That means that the patients themselves in that study got to choose if they wanted rituximab or not. The real way to do it is to do something called blind randomization, where patients say, I want to be in the study. You put half of them on treatment, half of them on a placebo. The patients don't know which treatment they're getting. And that avoids all of these biases where patients say, oh, well, I know I'm on the treatment. I must feel better. And so a good quality study has to be this randomized placebo-controlled study. And that's happening. We are doing something called the recital trial. And this is randomizing patients to get rituximab versus cyclophosphamide. It's basically like the Scleroderma lung study 3, where they're giving these, comparing cyclophosphamide to another drug, kind of like how we did it for mycophenolate. They're hoping to get 216 patients, but they've been recruiting in this study since 2014, and they're having a lot of trouble getting patients to agree to go in this treatment. But finally, we have recruited for this study, and the results are expected in the next year or so. And we'll anxiously wait, because if this does show that rituximab works, it will become easier to get access to the drug. Right now, it's very difficult to get access to rituximab because it's very expensive, and it's never officially been approved for this use. So the next thing I'm going to do is I'm going to move to the future. Where's the future of scleroderma lung disease? And the future of scleroderma lung disease is in this new drug called nintedanib. We're using nintedanib in scleroderma lung disease now. What is nintedanib? So nintedanib is a completely different class of medications compared to the other three that I've talked about. This is in a class of drug called anti-fibrotics. So whereas the first three drugs that I talked about all focus on the inflammation and the immune system, and they push down your immune system, nintedanib works on the body's ability to lay down scar tissue or fibrosis. Many of you will be familiar with the drug nintedanib, which also goes by the trade name Ofev, because it was approved for use in IPF in 2015. But until recently, IPF was the only disease where we would use nintedanib. There are potential advantages of nintedanib. And the first main advantage is, unlike all of the other three drugs I've talked about so far, nintedanib does not suppress your immune system. The other advantage is, because it works in a totally different way than the other drugs, it can be used in combination with other treatments, and maybe that will even make it more effective. But there are potential disadvantages of nintedanib. The disadvantage is that what we're doing here is we're slowing down your body making scar tissue. And so we don't necessarily make people better. What this drug is meant to do is to slow down progression. But the problem is that we still do expect our patients to get worse on treatment, and that happens in IPF. Patients get worse on the drug, but they get worse more slowly than they would if they weren't taking the drug. Because of that, because we're just stopping the body from laying down scar tissue, we can't get rid of the scar tissue that already exists. Also, nintedanib does not have any effects on the skin, the joints, the muscles, and the other parts of scleroderma lung disease. It only affects the lungs, whereas a lot of the other treatments I've talked about can help with the other parts of scleroderma. It can help with the skin disease and the joint disease and the muscle disease. Now, nintedanib is looked at in a study called the Census trial. The Census trial, which was published about a year ago, took patients and randomized them to get nintedanib or a placebo for 1 year. And they did this study in 576 patients. That's important, Now, why is that important? So you may not have noticed from the other slides that I gave, but I'm going to remind you of how many patients were in the other studies. So the Scleroderma lung study 1 that I showed you at the beginning with cyclophosphamide, that had 158 patients. The Scleroderma lung study 2 with mycophenolate, that had 142 patients. And that Rituximab study that I showed you had 51 patients. And now we're looking at a study with 576 patients. This is huge, right? This is essentially bigger than all the other scleroderma studies put together. And that makes it a much more powerful study. And it helps us to get much more confident in the results because we're not just doing 100 and something patients. We've got hundreds of patients. And what did we see in the census trial? When we look at lung function over time, the placebo arm is in light blue. And you can see all these graphs that I'm showing you, I've picked graphs on purpose that are all the same. Time on the horizontal axis, lung function on the vertical axis, and you want your FVC to be as big as possible. So you want your FVC to be as high a number as possible over time. And what you see on this graph is that the placebo arm, the light blue arm, you're seeing their lung function slowly go down over time. But the people who are in nintedanib, their lung function goes down over time, but it's clearly going down more slowly than the people on the placebo arm. Based on this study, nintedanib got approved for use in Scleroderma ILD in November of 2019. This is the first drug that is officially approved by Health Canada to treat Scleroderma lung disease. Now, you might ask, well, why didn't Health Canada approve cyclophosphamide or mycophenolate or rituximab? And the answer has to do with the numbers of patients. As I said, when you get bigger studies, you can be more confident that the results you're seeing are real. And so this study was big enough that Health Canada thought it was enough that they could approve the drug for using in this disease. Now, many of my patients, as soon as they hear about this, they're so excited they can't wait to start on it. But the question is, who's going to pay for nintedanib? Nintedanib costs in Canada about 30,000 Canadian dollars per year. In other parts of the world, it can be substantially more. So if we have any Americans who are in the audience today, in the United States, the cost is at least double, but in some places it can be as much as 4 times the cost in Canada. If you have private drug insurance, most private policies will cover the cost of nintedanib for scleroderma lung disease, but not all will, and a lot of them still have a very high copay or deductible where the patients have to pay some of the money out of pocket, and that can be a major barrier. As far as government coverage in Canada, we have something called the Exceptional Access Program. Negotiations are ongoing in Canada. I am optimistic that the government of Canada will start to cover the cost of this drug for our patients, but it probably won't happen until 2022 because the negotiations are going to take about another year. So when it all comes down to it, and I talk to other lung doctors about treating scleroderma patients, most of them just end up doing this. I tell them all this data, I show them all these studies, and in the end, they end up just doing this. They say, just tell me what to do. And so this is my algorithm that I've developed for my patients. If you have a patient who has, or if you are a patient who has confirmed scleroderma, the first thing to say is that we need to monitor you. And in general, we should monitor these patients about every 3 to 6 months. Now, there is a lot of wiggle room there. There are some patients where I'd be very comfortable following them every 8 to 12 months if they have very mild disease that has not been progressing over time. There's other patients where I may need to see them every 6 weeks if I'm really worried about them. But in general, patients with scleroderma lung disease should be monitored by a lung doctor about every 3 to 6 months. And we should be looking specifically for evidence of progression. If we see evidence of progression, then in general in my clinic, we are starting these patients on mycophenolate. The reason for this is that I have a lot of experience with the drug and I'm confident that it works. I'm also confident that the side effects are pretty minimal and the cost of mycophenolate is manageable. So this is my first line treatment. Now, There may be patients where I might even consider treating at the time of diagnosis. I may not wait for them to get worse. This is particularly true for the patients who have high-risk features. So patients who have a significant amount of their lung involved when they first come to my clinic, or if their lung function is very low even when they first come and see me. And if they're very early in their disease, and I think that like that fire, they're still burning really hot. If they're on mycophenolate and I see that they're getting worse, then the question is, where are they getting worse? If they're getting worse and it's predominantly the lungs that are getting worse, so they have very minimal skin and joint and muscle disease, in those patients, I would add nintedanib. So these patients would end up on both mycophenolate and nintedanib. On the other hand, if they're getting worse, but they have a lot of extrapulmonary disease, so what we mean by that is that active disease outside of the lungs, particularly we're talking about active skin disease, joint disease, or muscle disease. In those patients, I would either add one of rituximab or cyclophosphamide. And a lot of that will depend on access. Cyclophosphamide is very cheap. Rituximab is very expensive. And so unfortunately, the reality is that what I can get access to might make me decide what I can get. But if I can use rituximab, that's usually my preferred drug. Then the question is, what if you're on a combination of therapies, so mycophenolate and rituximab, or mycophenolate and nintedanib, and you're getting worse? Well, if you're on mycophenolate and nintedanib and you're getting worse, that's when I would add another drug. And I have patients who are on mycophenolate, nintedanib, and rituximab. Similarly, if I went down the left side of this algorithm and you were getting worse, I would add nintedanib to get you on 3 different treatments at the same time. But it is important to know that around that time that I'm starting to put you on 3 treatments for your scleroderma, we need to have things like discussions about lung transplant. Because at this point, I'm starting to run out of options. And if you continue to progress, despite being on what we call sort of maximal therapy, I'm not going to have a lot of other options. So if lung transplant is an option for you, then that's something we should consider. And that's basically my algorithm for treatment of scleroderma lung disease. So I always love this cartoon. What this says is, I'm sorry about your machine. I think I huffed and I puffed a little bit too much. We may not be there yet with scleroderma lung disease, but I can tell you that compared to when I did my training in the early 2000s, all of the studies that I've shown you are all published from 2006 and beyond. So the last 15 years have been a really transformative time in scleroderma lung disease. And we're not even using many of the treatments that we had used years before. And so I think it's an exciting time. I think we're moving forward. I don't think we're there yet, though, where like the big bad wolf, we're blowing apart the machine. I think we still have work to do, but I am excited to be part of that moving forward. So to summarize, scleroderma lung disease happens in about half of the patients who have scleroderma. And the risk factors for progression are early in the disease course, and patients who have shown progression over time. Immunosuppressive therapy may improve lung function. That's drugs like mycophenolate, rituximab, and cyclophosphamide. All of those drugs help patients by pushing down their immune system. Anti-fibrotic therapy is a new treatment for scleroderma ILD, and it does seem pretty clear that nintedanib slows the rate of lung function decline. This is the first drug that has been officially approved for use in scleroderma lung disease in Canada, and I think that that's a really exciting development. Before I finish off, I just want to say a thank you to all the members of my team. So just to let you know, at the Toronto General Hospital, I don't work alone. I'm thrilled to have 5 lung doctors, respirologists, or pulmonologists who work with me, depending on what part of the world you're at, what you call them. I also have a rheumatologist who works with our clinic. I've got a couple of administrative assistants, some research staff, and a nurse practitioner. And I really couldn't do what I do without their help. So a big thank you to all of them. And with that, I think I'm going to stop sharing my screen, and I'm going to hand it back to Sharon.
Thank you, Dr. Shapera. That was a really great presentation. I learned so much. And I've asked our audience to post their question. And the first one was someone said, in your presentation, you showed that half of people with scleroderma will get ILD. Does this mean everyone with scleroderma should get tested?
Well, that's a really good question, and we don't know the answer to that question. The problem is that although half of the patients with scleroderma will get ILD, a big percentage of those patients never really get sick with it, and they have what we call that subclinical disease that I talked about earlier. And the question is, what do you do about that? You don't want to commit those people to treatments too early if they've had mild disease that would never really get worse. So whether or not we screen everyone with scleroderma for lung disease is very hotly debated, and a lot of it depends on where you are in the world and who your main doctors are and what their practice is. I think it's not a bad idea for everybody with scleroderma to have breathing tests performed at least once in their lifetime. So it doesn't have to be at the moment that you get diagnosed, but if you're seeing this and you have scleroderma and you've never had breathing tests, you may want to ask your doctor to do breathing tests. If the breathing tests are abnormal, then you probably want to go down that rabbit hole and start to work it up. But even if the breathing tests are normal, it can still be useful to have that baseline so that if down the road you do develop things like cough and breathlessness, and then you go to see a lung specialist, you can say, oh, well, how do my current breathing tests compare to how they were a few years ago when I was feeling fine? So if my family member had scleroderma, I would probably get them a set of breathing tests. But I do want to be clear that that's not universally accepted. Some people think that it's kind of like other kinds of screening, like screening for prostate cancer. Some people worry that we're going to identify a lot of people who don't need treatments and we just make them worry for nothing.
Okay, thank you. Another person asked, if scleroderma runs in their family, does that mean that they will more likely get ILD?
Yeah, we know that both scleroderma and ILD can both run in families. And they can run in families together, where you can have multiple families that had scleroderma or rheumatoid arthritis related ILD, or they can run in families separately. I have some patients where one member of the family has scleroderma lung disease and another member of the family has IPF. We know that there's a lot of similar genes that cause these conditions, and so they can run in families. But it's also important to remember that the vast majority of people who have both IPF, scleroderma, and other kinds of pulmonary fibrosis, most of those patients don't have this run in their families. So, my general rule of thumb is to say that family members are probably at a slightly increased risk, but I don't think that means that every family member of someone with scleroderma lung disease should go out and be getting CAT scans and breathing tests. What they should do is, if you've got a family member with scleroderma lung disease or any kind of interstitial lung disease, if that's your family member and you start to get lung symptoms, you should probably be a little bit more aggressive about seeing a specialist. If you get a cold that lasts a few weeks, just ignore it. But if you get cough or breathlessness that lasts for more than 3 months, then you should probably go see your family doctor and say, hey, I have lung disease in my family. I think I should see a lung specialist and check this out.
Okay. So the next question to this person asked was, if they don't have scleroderma, but they know people in their family do, is there a test that they could take to see if they have scleroderma? Or?
Yeah, what you're really asking is, can we, there's two questions there. The first question is, is there a test we can do like breathing test or a CAT scan or something like that? And the answer is, really, scleroderma is not a thing that we just diagnose on blood work or on a CAT scan. What we need is symptoms plus a constellation of things, the right symptoms with the right blood work with breathing tests that show lung disease to make a diagnosis. So if you don't have symptoms, you just don't have scleroderma, because by definition, scleroderma is a disease. It's not just a blood test. The second question, though, is I feel like this person is asking a little bit about, well, if we know that this is a genetic thing that can run in families, can I be tested for those genes to see if I'm at risk of developing scleroderma down the line? And that is a very difficult question, but I'll tell you my opinion is that you should not be tested for that. And the reason is that, we don't know exactly which genes it is, and it seems to be a combination of multiple genes and multiple factors. So if you get tested and you have those genes, that doesn't necessarily mean that you're going to get scleroderma. It just means you're at risk. It doesn't change anything we do now. We don't give you new treatments. We don't start you on any drugs. So it doesn't have any real benefits for you now, but it does have downsides. If I find out that you have the genes that put you at risk of scleroderma or other kinds of pulmonary fibrosis, there are real downsides to that. First of all, you end up living the rest of your life with this cloud over your head, knowing that you got the genes, but not knowing if you're going to get the disease. It also makes it impossible for patients, or difficult for patients, to get things like insurance, disability insurance, health insurance. There's even a risk that people could be discriminated against, somehow someone could get access to your files or your records when you're applying for a job or something like that, and you may get discriminated against. So in certain kinds of families where there's very aggressive forms of fibrosis that's clearly associated with very well-described genes, we sometimes do genetic testing. But I would say that every year, out of the hundreds of patients with ILD that I see, I usually only recommend genetic testing for family members in maybe one every year or two.
Okay, thank you. You had mentioned all these drugs, and so there's two questions. There's one from Canada. They were wondering, how do they know that they are covered for this drug?
Right. So that's a really variable question, and it depends a lot on how old you are, where you live, what province you're in, and what your insurance status is. And that's the kind of thing that you really do need to talk about with your family doctor and your rheumatologist and respirologist. In Canada, now I'm going to speak more to the Canadian audience because we have a public payer system that pays for a lot of our drugs, and I can't comment about our people on the line from other parts of the world. In Canada, though, most of these drugs are covered by provincial plans in specific circumstances. So for example, in Ontario, if you're over 65, some of these drugs are covered. So mycophenolate, for example, is covered. Cyclophosphamide is covered. But rituximab can be very difficult to get. Nintedanib, as I mentioned, is not covered by our provincial plan. If you're under 65, we do have a program, and there are programs all over the country called these exceptional access programs that can get patients under 65 access to these expensive drugs that you would get if you were over 65. But there are hurdles to jump through, and it needs to be an application. You have to go to your pharmacist and talk about applying. And so the answer is that in Canada, we just don't have universal drug coverage. So I can't say to any one patient, oh, I can just write you a script, you can take this to your pharmacy and get it, and it'll be covered. Each patient has different scenarios, whether you're covered by private insurance, whether you have no insurance, whether you're covered by the provincial formula because you're provincial formulary because you're over 65, or whether you can get into this exceptional access program because you're on expensive drugs, even if you're under 65. And that's the kind of thing each person needs to talk about with their local doctors. And the doctors can usually help you navigate your local system to get access to the drugs.
Oh, thank you. And for that OFEV, nintedanib that you were speaking to, you said it was going to get coverage soon, like next year?
So I don't know, but I'm optimistic that the Ministry of Health will start to cover it. Our estimates are that it'll probably be sometime in 2022, but I think there's reason to be hopeful that it may be in late 2021. It certainly is not going to be any time in the next 6 to 8 months. But I do know for sure that the government is discussing it. I know because I was recently approached by the government to ask for me to interpret these results as sort of an objective observer because I don't have any shares in the company. And so I had a meeting with the Ministry of Health along with some of the experts that I know have been giving these lectures over the course of the month. And we had a recent teleconference with the government to give our impression of the drug. So I know that the government is looking into it. I can't give any guarantees, though, that the government will come out and say, yes, they'll cover it. But I'm optimistic. I think that this is a disease that only has one drug that's approved. usually the government will eventually pony up and start paying. The
Okay.
problem is the government doesn't want to pay. These are expensive drugs, and they want to drag their feet as long as they can. And so there is no official timeline. It's just all in the government's court. And so this is the kind of thing where if people want to do advocacy work, this is a great place where you can advocate. You know, the IPF drugs, British Columbia took many, many years before British Columbia started to cover the cost of OFEV and IPF. And I know, Sharon, you were actively involved in the advocacy to get the government to get off their feet and get moving.
Mm-hmm.
And this may be another time where we need groups like the CPFF and patients themselves to advocate, to reach out to their MPs and their MPPs and say, I've got this disease and I need this drug. Can you get it covered? And that works.
Yeah. Yes, the Canadian Pulmonary Fibrosis Foundation, we have submitted a CADTH submission. For all those that don't know, that's the Canadian Drug and Technology Program that we're putting an application through to say the very same thing as Dr. Shapera, that, you know, this is a drug that's vital to patients who need it. And
so CADTH is hearing it from all different sides, right? They hear it from the drug company who they don't really trust. They hear it from the patients who want it, but they're not sure if they can trust that or not, but they're also hearing it from the doctors. And so CADTH has been separately meeting with each of those groups, and that's exactly the meetings we're talking about. So that's really encouraging to know that the CPFF is continuing their really amazing advocacy work to get these drugs for patients. And I will tell you that I don't think that BC would even have coverage today if it was not for the advocacy work of the CPFF and the patients who've really made a difference.
Yeah,
in IPF, I mean.
Yeah, yes, we've submitted and we know that they're going to review it, and we hope to get a decision next year. That they just told me April 2021, and so once that happens, then we'll be motivating everyone to join us to put this
through.
Get
out there, exactly.
Yeah. Our next question for you, Dr. Shapera, is you talked about vaccinations. Can you talk about the COVID vaccination that you think that people are working on? Many people are concerned that with this rush or this perception of rushing for a vaccination, how safe do you think it is? Do you think that the standards will be the same as they usually, do for vaccinations, or people are very concerned?
Yeah, I think people are right to be concerned. I mean, this is scary stuff. It's a new disease. It's a new vaccine. There is a lot of skepticism about vaccines in general. I will tell you that I'm a very pro-vaxxer kind of guy. I've seen what vaccines do, and I've seen what the diseases do when we can't vaccinate. Like I see patients with terrible lung disease, not pulmonary fibrosis, but other terrible lung diseases from measles. I see people die every year from the flu. I know that vaccines can prevent those problems, and so I'm generally a believer in vaccines. But I think we do need to be cautious, and we need to balance this need that our patients have, where patients with underlying lung diseases like scleroderma lung disease, they're at very high risk. Data coming out from Europe suggests that patients with scleroderma lung disease, or any kind of pulmonary fibrosis or interstitial lung disease, who get COVID-19, they do not do very well. And so these are patients who are at very high risk from getting the virus. So I think when the vaccines do come out, we need to be skeptical. We need to review the literature in great detail. We also need to have trust in our healthcare providers and in our system. Again, we live in Canada. We're fortunate to live in Canada. In Canada, you'll notice there is very little politicization of access to vaccines. Like Justin Trudeau, and in our province, Doug Ford and the other premiers, no one's coming out and promising that they're going to ram in a vaccine that's going to come out before the next election. All of our leaders are saying, we're going to follow all of our usual guidelines. We're going to look at efficacy, which means effectiveness. We're going to look at safety, and then we're going to approve it based on previous criteria. I don't get any sense that in Canada there's any kind of push to approve something that's not safe. So would I necessarily run down to Florida to get a vaccine that gets approved by Donald Trump that isn't approved in Canada? I don't think so. Would I fly to Russia to get the vaccine that Vladimir Putin is giving to his people that hasn't been approved by Health Canada? I don't think so. But I do think that the people at Health Canada are really looking at this carefully. And so can I tell you to get the vaccine? I wouldn't say now whether you should or shouldn't. I think we need to wait and find out which vaccine, How efficacious is it? How much does it work? How safe is it? We need to balance that data. But I also want to let people who are skeptical, I just want to remind you that COVID-19, when you have underlying pulmonary fibrosis, is terrible. I'm not trying to cause, nightmares, and I'm not trying to spread fear, but the data out of Europe says that this is probably as bad as many of you are worried it is. So the vaccine would have to be pretty darn terrible, dangerous. The vaccine would need to be killing lots of people before I would say that the benefits of the vaccine are outweighed by its risks. And I doubt that we're going to end up with a vaccine that's killing thousands and thousands of people. That seems very unlikely, but we'll have to wait and see.
So, Dr. Shapera, this person wanted to know, do you think that rationally that we might have a vaccination available by next fall, or do you think that's being too optimistic?
No, I think that's a reasonable timeline. I don't think anyone really knows, but that is one place where we have a lot of our friends and colleagues from around the world who haven't done as good a job as Ontario and Canada had done so far, although everything may have changed this week, so don't quote me. But before this week, the general feeling was that within Canada, we had done a pretty good job of controlling COVID-19. Other places in the world, particularly our neighbors to the south, have not done as good a job. And to be honest, we have them to thank for that, because vaccine trials need lots of patients and lots of disease to know if they work. If I gave you a vaccine against Ebola in Canada, and I did a study in Canada for an Ebola vaccine, how would you ever know if it works? No Canadian has ever gotten Ebola. So I could give it to the whole population. I still wouldn't know if it worked or not. You need lots of the disease around to see if your vaccinated people are doing better than your non-vaccinated people. So in a way, we're almost fortunate that the rates of COVID-19 are so high in the United States that they've been able to enroll in these studies, and they have lots of COVID-19. I do think that it's pretty soon that we're going to start to see that these studies are showing results. There's some data that's expected to come out around the election time. I don't think it'll be out before the American election. But there is some data that it is expected in the end of October, early November, to show if the vaccines are working. If one of the vaccines does show that it works before the end of 2020, I think it's promising to think that at least some people, like the high-risk patients, will probably be able to get the vaccine before the fall of 2021. But I think it'll probably take another year after that before everybody gets vaccinated.
So how would one make a decision if a vaccination was available, of whether or not they should take it?
Yeah, so I think there's two parts to that. The first part is, as I mentioned, remember that COVID-19 kills lots of people, and a big chunk of people with pulmonary fibrosis, whatever the cause, will die if they get COVID-19. If the vaccination works and doesn't kill people, chances are you're going to want to take the vaccine versus not take the vaccine. On the other hand, there may be multiple vaccines, and the decision may not be that black and white. And so when the vaccines do come out, I would strongly recommend that you talk to your healthcare providers, and they should know the data. They won't just start every doctor in Canada right now is eagerly waiting the data so that they can review it. Even doctors who never thought that they were infectious doctors are looking at every paper that comes out about vaccines and are interested. So when the vaccine comes out, talk to your family doctor. If you're not comfortable that your family doctor has the knowledge necessary, talk to your rheumatologist or respirologist and ask them what they think. And I mean, there's a reason why you trust your healthcare providers. I was in school until I was in my mid-30s. I spent a lot of time studying so that I can provide my patients with real experience. Even when we come across new things like a new virus and a new vaccine, I still think that that experience allows me to interpret the data in a meaningful way.
Okay. The next question, someone's very concerned, Dr. Shapera, with all these COVID-19 survivors. Does that mean they're going to be a longer line to see someone like yourself if, for their care, because so many others will want to see you as well?
Yeah, I don't know the answer to that question. I don't think anybody knows. I think it really depends on how bad COVID-19 gets, how many people get it in Canada, of those people, how many actually end up with long-term lung damage from the virus? I mean, the majority of people who get COVID-19 who don't have pulmonary fibrosis or ILD to begin with recover with no long-term side effects. And even those who do get long-term side effects, lung fibrosis is actually a very minority of those patients. It's only the sickest of the sick that are left with lung fibrosis. And I don't know if we're going to be seeing them in the ILD clinic or not. Right now, I'm not seeing any pulmonary fibrosis patients due to COVID-19 in my clinic. You know, I see the odd patient in my regular non-pulmonary fibrosis clinic who had COVID-19, but we don't have like an onslaught of hundreds of referrals for that. So I don't know what'll happen, and I think it really time it will tell.
Okay. And do you have any other tips or suggestions for people to make sure that they don't catch COVID-19 other than wearing of the facial mask? What about having a visor over your eyes? Someone wanted to know that there seems to be a consensus that you should wear a face mask plus a visor because the droplets could get into your eyes.
Yeah, that person is pretty well informed, because I will tell you that there does seem to be some suggestion that a visor is helpful, a face mask is helpful, and the combination of the two may be more helpful. I will tell you that right now, when I'm working in the Toronto General Hospital, if I'm going into a room with a patient who has COVID-19, I am wearing both a face mask and a visor when I go into the room, and the patients are also wearing face masks. Patients are not wearing visors right now, but you know, we do think that there's an added level of protection there. The problem is that it may not be entirely practical, and it may not be comfortable to wear both those things all the time, every time you leave the house. And so I think that for every patient, they have to find their comfort zone. You know, most patients should be wearing a face mask. I think that it is pretty clear that we can control this virus by using face masks. That seems to be bearing out all over the world. But what's also clear is that the face masks are not enough. We need to also be distanced. We need to avoid public gatherings. We need to not be near people who are at high risk of having the virus. And would a face shield be an added level of protection? I think it probably would be, but it's hard to quantify, to say, oh, well, if you wear a face shield, that will add an extra 10% or 40% protection. I think there's some protection, but I just don't know how much it is, and so I don't know whether or not it's worth the cost and the discomfort. But everyone should make the decision that feels right for them.
Okay, and so Dr. Shapera, could you recommend how can one still go about exercising, going out, even though with this pandemic of COVID-19, someone wants to know how can they make sure they maintain their good health?
So I tell all my patients the same thing. The more you move, the longer you will live. If you sit on the couch all day, you will not live as long as someone who gets up and goes for a 5-minute walk every day. And that person will not live as long as someone who walks for an hour every day. That's just basic fact. So it is really important that all of our patients continue to try and get physical activity during the COVID-19 pandemic. Walking outside is very safe. I do not believe that you need to be wearing a face mask when you're walking on an empty street with no one else there. There's no COVID to be had. It's just not, it's not floating in the air on your street corner. It's coming from other people. And so when you're on your own or with people in your home who live in your home, I think that you can be outside, active, without any need for face shields, face masks, or anything like that. If you're going to be exercising near other people, then I think that you should be wearing a face mask. As the weather gets worse, people are going to want to exercise inside. Ideally, that should be in your home. If you have the capacity to go for walks in your home, if you have a treadmill or a bike, that's great. If not, you know, people underestimate how if you live in a condominium building, just walking up and down your hallway, which is probably empty, you know, most of the time those hallways are 100 meters long or 50 meters long and there's no one else there. That's exercise. You don't have to be at the gym. In fact, I would recommend not going to the gym. As far as that middle ground between the gym and your home, you know, should you be going to the mall and going for walks around the mall in the winter? I think it's, again, a very personal decision, and it depends on what things are like in your home. If you live in a place that has low levels of COVID-19 and you can go to a relatively deserted mall, then I think go for it. If you want to be walking in the winter, walking inside in a mall might be reasonable. On the other hand, if you live in Toronto, I don't think that you should be going to Yorkdale on a Saturday afternoon, even if you're wearing a mask and just walking around for leisure. I think that that's an unnecessary risk. If people want, just to finish off one last point, if people want more advice on how to exercise, I know, Sharon, that you in particular have a great resource on your website. If you go to the Canadian Pulmonary Fibrosis Foundation website, there's a link, I think, that says Living with PF. And in there, there's a link that talks about exercise. And there's a really great video that you guys made that's about 30 minutes long that talks about how people can exercise. It's not specific for COVID-19, but everything still applies about the importance of exercise.
Yeah. Yes. So I was just going to recommend that because it gives people ideas about what you could do ordinarily. You don't need to spend a lot of money to buy expensive equipment. Someone
like so many
asked,
of the other things that CPFF does, it's a great video and really is a great resource for patients.
Yeah. Someone asked that they heard that the University Health Network has a virtual program for exercise at home, and they were wondering if they don't live in Ontario or in Toronto, can they still access that and participate?
So there's a few different exercise programs at the University Health Network. And I'm not sure which one this person is referring to. The two that I'm aware of is one of them is for our patients who are on the lung transplant list. So back in the days before COVID, if you were on the lung transplant list, you came down to Toronto General Hospital 3 times a week and exercised in our rehab program. Because of COVID-19, we don't want to bring these very susceptible, very sick patients to the hospital if we don't need to. So for our patients who are listed for lung transplant, we've adopted very quickly a virtual exercise program for them. But that's only available to people who are specifically listed for lung transplant. At the Toronto Western Hospital, we have a really excellent pulmonary rehab program, which is an exercise program that used to be a program where people would come for the day. More recently, they've moved towards a more virtual platform. I don't want to give the impression that this is like a Peloton thing where like 5,000 people can all come and log in and watch the same exercise routine. It's a relatively small program that does service, a couple hundred patients. I don't entirely know the capacity to expand. For sure, that is not available to people who live outside of the province of Ontario. But if you do live in the province of Ontario and you're very interested, you could have your family doctor or your lung specialist refer you to the pulmonary rehab program at the Toronto Western Hospital. That's part of our group. And request that virtual program. I know that it's running. I just don't know how broadly they're enrolling.
Okay. And do you know any other websites that people can check? I know that CPFF, we try very hard to have a list of pulmonary rehab centers, but because of just what you said about COVID-19, most of them have shuttered down. And so we're trying to figure out if they've gone online or is there a new website that we can look and we could put it onto our website so people can reference to it.
So the only other website other than the video on your website that I'm aware of that I recommend to my patients is the one from the Toronto Western Hospital. So if patients go to Google or if our audience goes to Google and types in Toronto Western Hospital Pulmonary Rehabilitation Program, there is a nice link. They have a video that's very similar to the one that the CPFF has made. And on that link, there is some links that you can reach out to Moran Manji, who runs their program, and she might be able to give you more information. I'm not aware of any other resources elsewhere. I think a lot of the programs have shut down during COVID-19, and I think a lot of them don't have the resources to do online learning. But I suspect if this is going to be here long enough, it will happen over time. So you just need to talk to your local pulmonologist or your local respirologist and find out what they're aware of in their communities. I suspect that everybody knows about their local pocket of what's happening.
Okay. Dr. Shapera, someone wanted to ask you about diet. They were very concerned because with scleroderma and ILD, sometimes it's very hard to keep and maintain your weight. And so do you have any suggestions of where they can go to look up some for some videos or virtual suggestions about how to maintain a good healthy weight?
Yeah, it's a great question, and I'll be honest, I don't have a great suggestion, and the reason for that is that it's sort of a little bit of outside of my expertise. So scleroderma is one of these diseases that affects all different parts of the body, and the gastrointestinal or the stomach issues related to scleroderma is a really, really difficult and challenging area. There are some specialty clinics that actually deal with the stomach and esophageal problems from scleroderma, and so you can look into whether or not you need a referral to one of the local scleroderma gastrointestinal clinics, and they would have suggestions. But the reality is a lot of the suggestions that we make for weight loss and weight gain in our patients really are the same as any other disease. And so, you know, I think that if you have access to a dietitian or nutritionist or your family doctor, they can be a great resource and they can talk about things that you can do. But I don't have any specific knowledge or recommendations myself because it's really not my area of expertise, and I don't want to step out of my comfort zone and make recommendations that may not be based in scientific evidence.
Okay, thank you. I'm going to ask the audience if there are any further questions, because I recognize that we only have about 9 minutes left on our schedule. So if you have any more questions, please post them, and Dr. Shapera would be very happy to answer them, you know, as best as he can. And while we're waiting for questions, I want to share with everyone that we so appreciate all the ILD respirologists like Dr. Shapera for making these presentations and for, you know, educating us about how we need to take care of ourselves and to look after ourselves and advocate as well. As I want to thank Boehringer Ingelheim Canada and Roche Canada for supporting CPFF for us being able to provide all this platform session for free to everyone that wanted to come and attend today. And I also want to thank our audience for your feedback and comments. Please note that when you exit today, that there is a poll question we always ask people. It helps us to share with our speakers and our presenters about, you know, what other topics you're interested, and we would love to hear where you're from so that we could maybe next year build this even to a better platform. And so I want to thank you. And so looking at the platform, there are no further questions, Dr. Shapera. So thank you so much for today. And, you know, thank you for all your good advice, and thank you everyone for attending.
Well, it's my pleasure. Thank you so much for having me. And again, thanks to the CPFF for all the amazing work that they've done, both over the years and over the last month. I know these seminars have been really amazing, and it's been my pleasure to be part of them. And I think this, you're closing up the month soon. Is that right?
Yes, today you're our final presenter. So thank you so much for that. And I was going to remind everyone that this Saturday, October the 3rd at 1 p.m., we're going to do a wrap up and applause. So all these clips we're going to make into one big huge compilation, and we're going to show it to you, as well as for those who want to send in their tributes of remembering somebody or honoring someone, to please do that. So thank you.
Well, thank you again for all the great work you do, and thanks for inviting me to talk today.
Thank you. Take care, everyone. Bye-bye.